Good morning, everybody. My name is Dr. Mariz Abdo. I'm a lecturer of pediatric endocrinology, and today we're going to be talking about acute adrenal insufficiency and adrenal crisis. So what's the management of adrenal crisis? Adrenal crisis, as we all know, is a life-threatening condition, and the patient usually presents with dehydration and shock. And what's unique about the shock and acute adrenal is that it's not responsive to volume expansion alone. It should be associated with glucocorticoid administration. So the pillars for management of adrenal crisis are three: fluid replacement, steroid replacement, and treatment of precipitating causes. Regarding the fluid replacement, the aim is to restore the intravascular volume and correct electrolyte imbalance. First, I'm going to assess the patient. If the patient is shocked, I'm going to give him isotonic saline at a dose of 20 ml per kg over 1 hour, and this should be repeated up to 3 times if the patient is still hypotensive. This should be followed by continuous infusion of 2,500 to 3,200 ml per meter square per day, depending on the assessment of the patient and the severity of dehydration. So what type of fluid should the patient receive? It depends on the patient's blood glucose. So if the patient has a blood glucose less than 60 milligram per deciliter, first I should start by giving the patient a bolus of 2 to 5 ml per kg of glucose 10%. And then I should recheck the blood glucose and make sure that it's higher than 60. So now if the blood glucose is between 60 and to 80 milligram per deciliter, then the patient should be put on isotonic saline to glucose 10% in a ratio of 2 to 1 or 1 to 1, depending on the sodium of the patient. And if the blood glucose of the patient is above 80 milligram per deciliter, then the patient should get fluids in the form of isotonic saline to glucose 5% in the ratio of 2 to 1 or 1 to 1, again, depending on the sodium of the patient. So how long would I put the patient on fluid therapy? I should continue with the fluid until the patient is clinically improved, the lab has improved, there is no hypotension, no dehydration, electrolytes have improved, the sodium is above 130 milliequivalent per liter, and the blood glucose is above 80 milligram per deciliter, and also the patient could tolerate oral feeding. Regarding glucocorticoid therapy, the patient should be given IV hydrocortisone as a stress dose immediately as the patient presents to the ER. So in neonates, the stress dose is 25 milligram, in infants it's 50 milligrams, in children and adolescents 100 to 150 milligrams. Then the patient should be put on a dose of 50 to 75 milligram per meter square per day, divided every 6 hours, like into 4 doses. So in case the patient, we couldn't establish an IV access for the patient, then the stress dose should be given intramuscularly. And just know that hydrocortisone at the stress dose has a mineralocorticoid activity. Now that my patient has improved clinically and lab-wise, then we have to start tapering the dose. So the dose should be tapered by a 1/3 per day. And I should go down until I reach a dose of 10 to 20 milligram per meter square per day in cases of primary adrenal insufficiency. And in cases of secondary adrenal insufficiency, the patient usually needs a lower dose, which is 6 to 8 milligram per meter square per day. There are some notes that should be put in consideration during treatment of patients with adrenal insufficiency, that we shouldn't exceed a 20 milligram per meter square per day as a maintenance dose. We shouldn't be using prednisolone, or dexamethasone because they have a graft suppression effect on these patients, and the dose should be tapered over a period less than 10 days. Regarding the mineralocorticoid therapy, we should start fludrocortisone once the patient can tolerate oral feeding, and there are 2 kinds. There is acetylene H and cortisone. There are 2 kinds of tablets in the market. It's acetylene H and cortisone. The tablet has a 0.1 milligram, and the dose that we use is 0.025 to 0.2 milligram per day. So it's a quarter of a tablet per day to 2 tablets per day. Some patients require sodium supplementation, and we can give the patient up to 100 to 200 cc of normal saline per day. Of course, we know that hyperkalemia is a part of the adrenal crisis, and usually it normalizes with fluid and steroid replacement. But in case of patients having potassium level above 6 milligram per deciliter, they should be monitored with an ECG, and we should put them on cardiac monitor. And if we find the potassium level is above 7 milligram per deciliter and having ECG changes, then we should start the antihyperkalemic measures, which are calcium gluconate 10% over a period of 10 minutes. And sometimes we have to initiate insulin glucose infusion to decrease the level of potassium. So during treatment of patients with adrenal crisis, we should be monitoring the patient for dehydration status, their arterial blood gases, the blood glucose, the electrolytes, and their creatinine levels. So how to prevent patients from having an attack of adrenal crisis? Usually during illnesses, we advise the parents to double the dose of the glucocorticoids. So that's one of the things that would prevent patients from having an adrenal crisis. And vomiting in a child susceptible to crisis is really a serious thing and should be put in consideration. The patient should receive a stress dose, and a blood sample should be withdrawn to assess sodium, potassium, blood glucose, and we should observe the patients. Thank you.